Hello. Hello.
Hello, sir, you can start the session.
Yeah, and we'll wait for 2 more minutes. Just 2 minutes.
Okay.
People are joining on.
Good evening, sir.
Good evening. എന്താ കുറച്ചാൾ കാണാനില്ലായിരുന്നല്ലോ മുറേ?
നമുക്ക് വേറെ ക്ലാസ് ഈ ടൈമിൽ വരുന്നത് സാധാരണ അത് മാറ്റാൻ പറ്റുമോ നോക്കുന്നുണ്ട് സാർ, വേറൊരു ക്ലാസ് അതുകൊണ്ടാണ് സാർ.
No problem, no problem. It's not mainly meant
ഒന്നും
for you.
ആഗ്രഹമുണ്ടേ.
Okay, no problem, no problem. Okay then. We'll start. Okay then. Shall we start now? So
Yes,
good
sir.
evening. Yeah. So good evening to all of you. Today I will start with a spotter first, then go to the proper cases. Spotter case is very straightforward. Just to refresh our memory, all right. Now, what does this patient have? This eye movement problem. Look at the video and then the diagnosis. All looking at my finger. Okay. Or keep on looking at it. മോളിലോട്ട് നോക്കുക. Okay, ഇനി ഞാൻ പറയും. So that's the story. Now, anyone like to voice out what could be the problem in this patient? You want to see the video once again?
Yes.
Yeah, I'll show the video once again. Nothing great, simple case. All looking at my finger. അടുത്തോട്ട് നോക്ക്. Or keep on looking at it. ഇനി ഇടത്തോട്ട് നോക്കിക്കേ. മുകളിലോട്ട് നോക്കുക. Okay, ഇനി ഞാൻ പറയും. Okay, any thoughts?
Bilateral eye.
Okay, very good. Bilateral eye. Now, sometimes it may be difficult. When you do only the pursuit movement, may be difficult sometimes. In that case, ask you to do a large amplitude second. Let us see the second video. Then become more easy for you. Let us see this one.
Okay. Left, right, fast as you
Then it
can.
become very
Left, right, left, right. Okay. ഇനി എൻ്റെ വിരൽ ക്യുക്കായി വിരൽ കാണിക്കും കെട്ട് നമ്മൾ പെട്ടെന്ന് നോക്ക് ക്യുക്കായിട്ട് നോക്കിക്കേ right left.
Apart from the restriction, is called adduction lag.
Keep on looking at my finger. Keep on looking at my finger. Keep on looking at my finger. Up.
Yes, also looking up, there is an upbeat nystagmus. Okay. So the thing is, suppose you are not able to make a quick saccade or a fast saccade. To make a fast saccade, you have to go to a large amplitude saccade. Because as you know, the velocity is dependent upon the amplitude. You cannot increase your eyeball velocity by your own. If you ask people to do a large amplitude saccade, the velocity will be larger. Small saccade means large amplitude will be lower. Then you will be able to make out this adduction slowing very evident in the adducting eye. Now, my question now is, so the adduction slowing becomes very prominent or large amplitude saccades. Now, what's the explanation for the upbeat nystagmus in this? Did you notice upbeat nystagmus? Or looking up?
Yes.
Yeah,
Yes, sir.
right. Okay, what is the explanation for that? Why should it occur with the bilateral eye and no?
Because of something to do with the vertical movements. The some of the posterior circular canal connection is affected. So the forget. So it produces downward movement in the upward saccade.
So you mean to say that it is the involvement or the connection between the superior subsacral canal to the occipitalis muscles here, and this was producing that there is a ventral tegmental tract.
Because affected, the MLF is affected. The thing, the fibers pass through the MLF.
No, that fibers pass through the to the ventral tegmental tract. The PCC, posterior subsacral canal, passes through the MLF.
Posterior subsacral canal usually causes
going through the
downward.
MLF. Yeah, that will produce a downbeat nystagmus.
Yeah, so maybe the tegmental, nearby tegmental tracts are also involved.
Okay, so that's your explanation. Okay, any other explanation? Anyway,
RIMLF lesion, sir, because bilateral MLF lesion involved in the RIMLF.
But there you have to, MLF lesion, classically upbeat nystagmus described in dorsal midbrain lesions. So there you have to take the lesion to the midbrain. Do you think this patient's got a midbrain lesion? Or anywhere maybe in the bilateral MLF may be affected? I'll come to that point later on.
Accessory MLF.
Accessory?
There's something called accessory MLF, no?
No, that's a different thing. That's for the upward restriction seen in lateral lesion. Now, this is a very simple explanation. I'll tell you what's explanation. See, if you want to, if you look at the pathophysiology of the gaze of nystagmus, it is a leaky neural integrator, which we all been talked about that late before, very much before. That is when you keep the eyes on eccentric gaze, there is a pulse and a step. Pulse is the one which make a saccadic movement to one eccentric point. To keep the eye in the eccentric position, there has to be a step innervation that is provided by the neural integrator to maintain the eye in the eccentric position so that the eye will not drift back to the primary position. So for the horizontal saccades, the neural integrator is in the nucleus propositus hypoglossi and the medial vestibular nucleus. As for the vertical saccades are concerned, this neural integrator is in the interstitial nucleus of Cahar. So here, either lesion of the interstitial nucleus of Cahar can produce a gaze-evoked nystagmus or looking upward. But remember that all these neural integrators, be it in the nucleus propositus hypoglossi for your lateral gaze, eccentric gaze, lateral gaze, or for upward gaze in the interstitial nucleus of Cahar, these integrators are to be stabilized by the flocculus. That is why you get the floccular lesion is the classical site to produce gaze-evoked nystagmus. So similarly, for the upward gaze also, the neural integrator, which is the internuclear kahar, which is situated in the midbrain, has to be stabilized by the input from the flocculus. That input goes through the MLF. That is why what happens looking up, the eyes cannot be sustained in the upgaze, so it drifts back and you get a upbeat nystagmus. It is nothing but a gaze walk nystagmus looking up. That is why you get a upbeat nystagmus in bilateral MLF lesion. Okay, this is the one already told, integrated vertical saccades and the intestinal kahal. Just like the neural integrator, the horizontal saccades, which resides in the nucleus glucosidus hypoglossal in medial nucleus, has to be stabilized by the flocculus, which ascends through the MLF. When there is a leak in the MLF, the eyes cannot be kept in the vertical eccentric position of the vertical gaze and drifts back to the primary position, resulting in vertical gaze of nystagmus. Okay, now the question is it deletion in the midbrain or is in the pons?
Convergence.
Pardon? Yeah,
Convergence.
very good, very good. You are doing the convergence. Let us see the convergence.
Go on looking at the finger.
Very good convergence is intact. That tells you it's most likely to be an inferior INO. That is below the midbrain. That's likely site. Even implementation sometimes can spare convergence, but it's more likely to be a pontine lesion.
Go on looking at the finger.
Moreover, convergence you have to do to differentiate from isolated medial rectus paralysis also. So this is the MRI of the patient. This is the T2. Flare. Digital flare.
She is a possible positive ആണെങ്കിൽ
Okay, there is no lesion seen. What happened now in this patient?
Need a coronal thin cuts.
Yeah, and before that, sometimes bilateral amyloid, a very small lesion is enough to produce bilateral amyloid. So sometimes it may be missed, as Joy was telling you, to take a coronal cut, or a thin cut has to be taken to find out whether this lesion is there. Even if you don't find a lesion, there is a lesion. That's it. Now let us see took a sagittal cut and adjusted the window width. There you can find out there is a lesion. You can see the dorsal part here.
That's a typical site of an MLI.
That's the one arrow pointing to. That's a lesion on the producing the dorsal aspect of the pons. In fact, if you look at the flare also, if you take it carefully, you can look at there is some hyperdensity seen near the facial colliculus. That is where the MLF is situated. I don't know whether it's correct or wrong, but there is some hyperdensity seen there. Correlating with the clinical finding, that may be the culprit lesion. That can also be seen in the sagittal cut. Okay. Any questions before I go to the proper case?
Is there a INO for the vertical gaze?
INO?
For the vertical gaze.
Internuclear ophthalmoplegia for the vertical gaze is not there. You can have a unilateral upward gaze palsy is described. Monocular upward gaze palsy. That some time back, I had shown one case, where one patient had, looking up, only one eye goes upward, the other eye does not go up. Similarly, you can have a supranuclear downward monocular downward gaze palsy. When looking down, one eye will go down, the other will not go down.
But there's something called vertical 1.5 syndrome, no?
Vertical 1.5 syndrome is there, correct. Vertical 1.5 syndrome, that is there. That is different from this internuclear ophthalmoplegia. Vertical 1.5 syndrome is that they got a vertical gaze palsy, one upward gaze palsy, and one eye is downward movement is seen on the other side. The other way also called vertical 1.5 syndrome. It can be either upward vertical 1.5 syndrome or downward vertical 1.5 syndrome. Okay. I think I don't know whether I've made myself understood. Vertical 1.5 syndrome mean there are two vertical gazes, upward gaze and downward gaze. In vertical 1.5, one gaze is lost, the other gaze is partially affected. That is vertical 1.5 syndrome. Only one eye will be moving down, the other or one eye will be moving up. Okay, shall I go to the next case?
Yes, sir.
Okay. This is a story of a 60-year-old man. His complaint started as acute onset of left-sided weakness, associated facial deviation to the left side, numbness of the left face, and was noticed to have a squint. The weakness improved to a great extent after 2 weeks, and on recovery, he found that he has defective vision, and his left hand will go astray and would move away from him without his awareness, and may even push the plates on the dining table. So once again, the complaint started as acute onset of left-sided weakness associated with facial deviation to the right, to the left, numbness of the left face, and noticed to have a squint. The weakness improved to a great extent after 2 weeks, and on recovery, he found that he has got defective vision, and left hand will go astray and will move away from him without his awareness, and even may push the plates on the dining table. I'll show the video of the patient. This is the video of the patient. The patient is looking straight ahead, and you can see the eye movement. Eyes remain converged a little bit. Looking to the left side, left eye abducts almost normally, right eye fails to abduct completely. Looking to the right side, no abduction on the right side, partial abduction on the left eye. Upward movement seems okay. Downward movements you can also see apart from the vertical nystagmus, you can see some broad nystagmus also. Ask you to look to the left side again. Checking the ocular cephalic. You can right eye does not move. Left eye moves almost relatively normally. There's no movement of that. It's got right, so pulse mainly in the lower part. Parietal movements are normal. Tongue normal. Look for any parietal involuntary movement. It is not there. Parrot is normal. The motor system examination. Tone is normal. And you're keeping his hand straight, the left hand will go down, drift downward slowly. And there's some kind of an atherotic posturing of the left, definitely an atherotic posture on the left hand. And keeping his, looking at his hand, look at the hand, what is happening, closing the eyes. Left hand goes down. The thumb gets adducted. That's going to finger nose testing. Almost normal on the right side. Left side is difficult because causing the abnormal posturing. Whether it's ataxia or not, we are not very sure. See that the way hand goes into taking the same thing. Some incoordination also is abnormal posturing plus incoordination.
ഇനി ഒന്ന് മുറുക്കി പിടിക്കാൻ നോക്ക്.
Power is normal on the right side.
ഇതൊന്ന് മുറുക്കി എന്റെ കൈ
Left side also actually power is normal.
വിട്ടെ മുറുക്കി പിടിക്കേ. മതി വിട്ടോ. കൈയിനെ പൊക്കി പിടിക്കണേ.
Proximal power also is normal. Ask him to keep his eyes closed. Shows again the abnormal movements.
ഈ കാല് ഒന്ന് പൊക്കിക്കാൻ മുകളിലോട്ട് പൊക്കി പിടി വിട്ടോ.
The volume power was normal.
പാദം മുന്നോട്ട് പിടിച്ചോ. സമ്മതിക്കല്ലേ, ഇതിനെ പിടിച്ചോ. സമ്മതിക്കല്ലേ.
Okay, that's normal power. Now come to the reflexes. Normal in the upper limb bilaterally. It's still triple bilateral. Lower limb just elicited. Plantar was flexor, or probably rather indefinite. We are not sure about it. Anyway, it's not ongoing. Come to touch sensation. Touch is counting, insistent counting on the left side. Sometimes it misses the counting, but in all other areas it counts very well. I said correctly. There he missed on the left hand. Then his tactile localization is okay. There is no tactile inattention. But pain is decreased on the left side. There is an altered sensation when the pain with pain. There again it's decreased on the left side. But he said vibration decreased on the left side, but still able to feel that. Then Jeffrey sense is normal in the right hand, but totally lost on the left hand. He does not know. He made a mistake. Again made mistake. Again made mistake on the left foot. Graphesthesia is correctly on the right side. He again made mistake. He couldn't say what object is held in his left hand. He said correctly on the right hand. So this is the finding. Then on looking at the gait, his left upper limb goes into an elevation, spontaneous arm levitation, and goes abnormal posturing on the wrist and the fingers. Seems to mild spasticity on the left lower limb.
So did you say about facial sensation and corneal reflex?
I forgot to mention that he has got decreased pain on the left side of the face. Corneal reflex was normal on the left side. So let us see. So what are the findings in this patient? I think I'll break up into small videos so that make you. I mean, it should explain that way. Now let us see the eye movements first. On looking, this is what is on looking straight ahead. Both eyes seems to be in a converged position. This is on looking to the left side. Left abduction seems almost full. Right adduction is restricted. Means his right middle rectus is weak or maybe right partial eye. Correct? Now looking to the right now, total absence of abduction on the right side. Left eye adducts, but only very minimal. There's a gross disconjugation even looking to the right side. So it cannot be a right gaze palsy. So means that either there is a right lateral rectus plus left INO, or a right gaze palsy, or left medial rectus weakness. So right lateral rectus has to be involved anyway. The adduction failure could have been due to left INO, or adduction failure could have been due to the associated right partial gaze palsy, or could have been due to the left medial rectus weakness. Any of these possibilities now exist.
One and a half
Despite this.
syndrome on the right side. One and a
Okay.
half syndrome on the right side with absence nucleus affected.
Okay. The problem with the one and a half syndrome is that thing. It's not only one and a half syndrome. In one and a half syndrome means involvement of the gaze center plus associated amygdala. So that can explain it. What is against that possibility?
The full abduction loss could be because of the absence nucleus is involved.
Yeah, correct. Because if it is a gaze center involved or the PPRF involved, the restriction should have been equal on both sides. Here, the right abduction is nil, left abduction is partial. So the abducent could be the abducent nuclear complex, but the abducent nucleus per se is maximally affected. You got the point. So it is gaze and abducent nucleus center maybe it's not at all in the PPRF. It has to be the abducent nuclear complex, but not the center per se. The nucleus plus the interneurons are affected. The nuclear portion is more affected than the interneurons. Am I clear to you?
Yes, sir.
So that can explain why there is gross disparity in the abduction and the adduction. In fact, it's some kind of an one and a half syndrome. Only thing is that there is an inappropriate or excessive involvement of the abducent nucleus per se than the center itself. So it's got a right lateral rectus palsy with right lateral gaze palsy or right eye. Okay. Then facial deviation to the left side.
Right lateral gaze palsy or the left lateral gaze palsy?
And because right lateral gaze palsy, abducent nucleus plus right lateral gaze palsy means to explain the adduction failure of the left eye. Okay. Okay. Because two are not equally affected. See, if it's a total gaze palsy, you can explain the right abduction failure. But that degree of abduction failure, so that degree of restriction should be there on the left medial rectus organ. That's not there. So it has to be a partial gaze palsy to account for the left adduction failure and a complete abducent nucleus involvement to explain the right lateral rectus. That is why I put it like that. Then he has got a facial deviation on the left side. He has got vertical, occasionally rotary, pendular nystagmus. What is the type of nystagmus he has? He's got a pendular nystagmus. If you look at there's no fast component, only slow component. It is moving like a pendulum. Impaired touch, pain, vibration, joint position sense, defective osteognosis on the left hand. And left hand shows atherosclerotic dystonic posturing and left arm levitation. So where do you like to postulate the lesion in this case?
The right pons and probably the right parietal lobe also because the cortical sensory impairment.
Yeah, that can be explained by involvement of the ascending tracts in the brainstem.
Thalamus.
The right pons.
Thalamus, you cannot explain the eye movement abnormality. As Joy was saying, invariably you have to postulate on the pons. Because right sixth nerve is there. Plus right gaze palsy is affected. Right MLF is also affected. So that means there is no other side which can explain. You have to implicate a right pons. But you have to explain other phenomena. How do you explain that?
Which phenomenon?
Pardon?
Which phenomenon?
No, all of the findings how do you have to explain? All which I mentioned.
Sensory things could be because the medial lemniscus.
Yeah, correct. So ultimately the posterior column sensation is going through the medial lemniscus. So that also, along with lateral parathalamic tunnels, can be affected. So right-sided pontine lesion, if it's little large and laterally situated, can also implicate the medial lemniscus as well as the lateral parathalamic tract. Medial lemniscus is a little more anterior, lateral parathalamic more lateral. It may be a fairly large lesion. So it can thus explain his cortical, so-called cortical sensory loss. So cortical sensory loss means, or if you have got a joint position sense and touch loss, everything, you can have cortical sensory also invariably lost. To say cortical sensory loss, the primary modality should be intact to say cortical sensory loss. They're also lost, you cannot say about the cortical sensory loss. So if that's also lost. So yes, that can be explained by the fiber tract involvement itself, may not implicate the parietal. Now to explain the facial deviation to the left side. Mild facial deviation.
Then the right pontine lesion.
Yeah, there may be a partial element facial weakness on the right side. Very good. How do you explain the pendular nystagmus, which is vertical as well as rotary?
Because of the MLF involvement.
MLF involvement will not produce that thing.
Central tegmental.
Or the
Will
medial
produce
tegmental tract.
Central tegmental.
central tegmental tract.
Central tegmental.
It's connecting the red nucleus with the inferior olivary nucleus. Okay. Atherotic dystonic posturing again due to sensory deafferent. Okay, that was the sensory input is not there. This I many times I've shown that even parietal when a spinal cord lesion also can produce arm limitation when the proprioceptive input is lost. Okay, so that's a site of lesion. You all said correctly. Now let us, in addition, what do you think about the eye from the left eye in this patient?
It's a convergent spasm.
There is left eye is also affected in this patient. See, that you don't expect here, right? We have got a right one-and-a-half syndrome, right? Right atlectus is paralyzed and right gaze is affected. Left adduction failure, I can explain. Why should it go into abduction? So reduction of the left eye.
Convergent spasm.
Yeah, there must be a convergent spasm. Two possibility. One is convergent spasm or a partial left atlectus weakness. Although it's a pontine lesion, you can go to the other side as well. But you have to explain a large lesion to explain that thing. So it most likely a convergent spasm. Most likely the former. Now,
convergent spasm usually happens in midbrain lesion, no?
Midbrain lesion, correct. So that pontine lesion has to go up to involve the midbrain lesion. Or the right-sided pontine lesion has to go to the left side to implicate the abducing nucleus. Both way partial. That's only way to explain the this thing. Adduction of the left eye. Since the abduction movement is relatively normal in this patient, because in the first picture I showed you, see, here is on looking to the left side is almost normal. So most likely it's a convergent spasm. So let us analyze eye movement abnormality first. Right pontine lesion to explain the producing 1.5 syndrome due to, remember the qualifying 1.5 syndrome, due to lesion abducing nuclear complex with significant affection of the right sixth nerve nucleus per se. That is the point. Then the lesion of central tegmental tract explain the vertical pendular nystagmus. Probable extension of the midbrain to account for the convergent spasm. This is localization. So just to exemplify this diagram I have shown you many times just for easy understanding. This is the PPRF, which has gone to the abducing nuclear complex through the left to the opposite third nerve nucleus. Similarly, if the opposite side goes like that. Okay, if there is lesion here, that is abducing nuclear complex, where the lateral rectus part, the dark green part is mainly affected, you get abducing nucleus will be maximally affected. The interneurons, the less, light green part is affected, you get a adduction failure of the opposite eye. Okay, that's the interneurons for the contralateral medial rectus. In addition, that lesion encroaches onto the right MLF, producing the adduction failure of the right eye. Okay, that is again the so-called 1.5 syndrome. But this can explain the patient's findings in this patient. But this also can produce 1.5 syndrome, but that is not possible in our patient. If that is so, should have been an equal restriction on either of the right eye, right abduction and left eye adduction. So this possibility is unlikely because in that case, you won't get marked restriction on the right abduction and minimal restriction on the left eye adduction. I think I made it clear to you why I postulate a right lateral is also involved. So this invariably will point to a lesion in the pons. Now, what is explanation of vertical nystagmus? This triangle, all of you know, that is a connection of the right nucleus to the central tegmental tract, the inferior olive, invisible epidemic. What do you normally expect in the case of a central tegmental tract lesion, apart from the pendular nystagmus? Palatal nystagmus. But
Palatal myoclonus.
palatal macula. But in this patient, did not have any palatal macula. I showed you the palate. Nothing was seen in the palate. But still, that's a set. Facial elevation on the left side, partial effect on the seventh nerve. Impaired sensation of all modalities, mainly posterior column on the left side of the body. Affects the medial lemniscus and spinal lesion is right pons with extension to the midbrain. So this is the MRI which was brought to me when the patient, 5 months back when I saw the patient first. This MRI was taken earlier. This is taken 22. So this is the MRI. This is CT scan taken. Shows hyperintensity in the dorsal pons. Also extending to the right side as well as the midline region of the midbrain. This is affecting the pons and the midbrain. This is the CT scan uppercut. Then this MRI is brought again by the patient. This is the flare. This is SWI. So what is the diagnosis? Etiology now. You want to see?
Kavanoma.
It looks like a cavernoma. Very good. It's a cavernoma with the bleed. That is the most likely site of lesion. Okay, at least I don't go into etiology for the lesion. Now, if you can repeat MRI when the patient is admitted, and this is when they saw the patient now. So this is MRI now. This is the diffusion. So that areas become hypointense. This is the ADC. This is the flare. Now look at the flare images now. It's a pons. There's hypointensity. See, there's one lesion there in the middle. What is that thing?
Inferior olivary nucleus.
Okay, that is inferior nucleus hypertrophy. So now the patient has become that is responsible for the vertical pendular nystagmus in this patient. Vertical rotary nystagmus. It's only confined to one side, not on the other side. Only on the right side it is there. Okay. That is a inferior olivary hypertrophy. As you all know, that will not be seen in the initial MRI, may be seen only later on. Because the loss of inhibition of GABAergic neurons from the inhibiting neurons on the red nucleus, which is disrupted, you get a hypertrophy of the target neurons as inferior olivary nucleus. Ultimately, the target neurons going to atrophy also. This is the SWI. Sorry, gradient and this SWI. You can still see the blooming, and that is hyperdensity in the medulla of inferior olivary nucleus. And this time it also shows that there is an area of SWI hypointensity in the left parieto-occipital area also. Probably another cavernoma situated there. Okay, this is the T2. That's a typical appearance of a cover. Off-on appearance of the cover.
അവര് ഹെമറേജ് മാത്രം എടുത്ത് ട്രീറ്റ്മെന്റ് ഇമ്പാക്ട് ട്രീറ്റ്മെന്റിരിക്കുകയാണ് ഇമ്പാക്ട്.
So that's a hyperdensity seen in the Oliveri nucleus. That's a cover. I think we'll skip that. I think that's a cover normally. Now, what do you find here in this patient? One interesting finding is there in the midbrain. You look at the right nucleus and this right nucleus. This is larger, this is atrophied. Okay, so that means the lesion has been there in the right nucleus also. But it has got an importance. I'll come to that later on. Okay, that's atrophy of the right nucleus on the right side. Now, this patient is followed up after 1 month. This is 1 month later. The eye movements remain the same. Not much improvement at all.
അറ്റത്തോട്ട് നോക്കിച്ചാൽ തുമ്പത്ത് നോക്കിക്കുക. ഇവിടെ ഇവിടെ കണ്ണ് മുറുക്കി അടിച്ച് വെച്ചാൽ മുറുക്കിയാണ്.
I think I'll skip the. See, look at the palette now. No, nothing to be seen. No palatal nystagmus seen now. Other findings remain the same. It's got incoordination, dystonic positioning on remain the same without any improvement. And I'll skip that part of the video. Then 2 months later, now this is 2 months later. Now look at the patient now.
ഇനി വലത്തോട്ട് നോക്കിച്ചാൽ
There's no improvement in the eye movement.
താഴെ എന്റെ വിരലിൽ തന്നെ നോക്കിക്കോ. പല്ലിയാണ് ഈ കണ്ണു മുറുക്കി അടക്കി മതി.
Now look at the palette now. You can see, do you see the nystagmus on the right side? Confined to the right half of the palate. Do you see that? The palatal nystagmus now come after 2 months on the right half of the palate. It is confined to the right half. I don't know whether you can make it out or not. I'll show that lateral part once again. See that movement?
Yes, sir.
Yeah, right. So that's it. So here, these abnormal movements come develop later on, not in the immediately after the insult. So palatal tremor on the right side is seen. Now look at the other phenomena which you observe.
വിറങ്ങ് നോക്കൽ വിരലിൽ തന്നെ നോക്കൽ.
The choreothetic movements also worsen now.
കൈ മുറുക്കി പിടിക്കച്ച വിട്ടെ കൈ ഇങ്ങനെ നീട്ടിക്കേ.
No, it is much worse. He said it's much more worse than before.
കൈക്ക് ഒരു ചെറിയ മൂവ്മെന്റ് അത് നമുക്ക് ഭയങ്കര അസ്വസ്ഥതയാണ്. നമ്മളത് കൈ തന്നെ കോൺസെൻട്രേറ്റ് ചെയ്ത്
He said it's become much disturbing for him now.
മൂവ്മെന്റ് ഇല്ല.
It was much worse than before.
അച്ഛൻ കടലിൽ കയ്യിലോട്ട് നോക്കണം. നോക്കിക്കൊണ്ടിരിക്കേ. നോക്കിക്കൊണ്ടേയിരിക്കണേ.
Previously, it was not that. It was not.
കണ്ണടച്ച്
It was only very mild. Now it is worsened now.
കൈ മുറുക്കി പിടിച്ചോ. കൈ ഇങ്ങനെ പൊക്കിക്കേ. വേത്തോട്ട് നീ കൈയുണ്ട് ചെയ്ത് പാടായിരിക്കും. നെറ്റി തൊട്ടാലും മതി.
See, in the first video, he was able to do better testing on the left side. Okay, so he's now developed right palatal nystagmus and his subtitude dystonic posture in the left hand has increased. Now the MRI was repeated, and this is what the MRI showed. What do you look at? What do you see in the MRI? This is the brain medulla, where it showed hyperintensity earlier on the right side. This is the pons. Again, medulla.
Atrophy.
Yeah, it has gone on to atrophy now. The bulge on the, or due to the olivary nucleus is decreased on the right side. Shows atrophy of the right anterior medulla. You can make it out on the right side. This is what happens in persons with inferiority hypertrophy. Hypertrophy occurs only for a few months. After some time, it becomes atrophied. So if you see a patient years later, you may find only slit-like olivary nucleus. That also I will show later. What is causing what is causing is worsening of the chorioathetosis just occurred now. At the very beginning. Pardon?
Tremor.
No,
Can you solve the red nucleus?
Yes.
yeah, correct. The thing is that many sites of lesion in the brain, when it produces involuntary movement, it may not be seen in the acute phase. It occurs much later. Classically, as I said, in red nucleus. In the classical rubral tremor due to an acute lesion, the stroke, you will not find involuntary movement, very mild only. But as months pass by, it becomes more severe and gross. This is seen not only in brainstem, maximally seen with any basal ganglia lesions. And classically, infantile hemiplegia and all, the person with cerebral palsy, they won't have involuntary movement initially. Years later, sometimes it can occur as years late as 20 to 30 years. This involuntary abnormal positioning occurs in the infantile hemiplegic site. So why this is occurring, we still do not know, because of the abnormal reorganization of the fiber pathways. Whatever it is, this can occur much later. That is called the late appearance of the involuntary movement in acute strokes. This is one of my patients which I had shown earlier. This is again a cavernoma. This cavernoma which has been years back. Now has come with hyperdensity, slit-like hyperdensity in the anterior medulla. This is the cavernoma. This is the hyperdensity of the medulla. This has gone into atrophy. The inferiority nucleus has gone to atrophy. These are the literature again, the initial phase, showing hyperdensity bilaterally. This initial one. Later on, that is a slit-like hyperdensity. So if you see the patient much later, sometimes you may even miss the lesion, the olivary nucleus, unless you look for. These are the literature, the evolution which is mentioned. So these patients followed 2 months later. That is 4 months after the initial. Yes, improved. The sensation is improved. It is still abnormal, but some of the functions has improved. He said correctly, which he was not able to say earlier.
3.
That tells you the lesion is not in the parietal lobe, because he has got lost all joint sense, but still when he could not recognize. Had severe impairment to JP sensation, but normal graphesthesis suggesting the lesion is not in the parietal lobe to account for the impaired JP sensation. So this is from the literature. Post-stroke movement disorders reported 56 patients. They said that dystonia was the most frequently related to infonucleus lesions, particularly involving putamen. They can be seen late on this. Late development of movement disorders can be seen in brainstem, spinal cord, and cerebellum. And 2 patients with foot dystonia had severe proprioceptive deficit. So I brought this case to elucidate that 2 things. One, the evolution of the central tegment tract lesions, where the voluntary movement of the parent can appear much later. Similarly, in rubral lesions or brainstem lesions, the baseline lesions, the involuntary movement may appear much later, may not be present in the initial phase. So that should not take it as a lesion, an evidence of progression of the lesion. Okay, any questions?
Sir, is it a rubral tremor or just a
No,
dystonia?
it is not a rubal tremor. It's not a rubal tremor. It's not a tremor. It's not a rhythmic quality at all. It's an abnormal posturing. And it's got a pseudo-athertotic, athertotic dystonic posture due to the loss of proprioceptive.
We can classify it as a dystonia.
Yeah, it's a dystonia. And so athertosis nobody uses now. It's also called dystonia only.
One more thing, sir. This convergent spasm, can it
Yeah.
persist for long?
Yes, it can persist for long.
How do you say it's lateral rectus weakness and not simply because of convergent spasm?
On the right side.
Yeah,
Yeah, because
both the
it's a
sides, the lateral
because
movements are
if
restricted
it is a
because of.
convergent, if it's a convergent spasm, it should be symmetrical, present on both eyes. Here, what is happening is that right eye is not at all abducting. Left eye is abducting. So it's not a convergent spasm. I mean, it's not a convergent spasm alone.
Can we overcome convergent spasm by dorsal movement?
No, it cannot be overcome because it's a spasm which is occurring. No, it cannot be overcome by a kind of dorsal maneuver.
Can it be overcome by closing one eye?
Closing one eye also is sometimes difficult because it is not the binocular vision which determines that. It is a spasm of the overactive the convergent center. And most of the convergent spasms are actually functional. People make it convergent spasm. That can be overcome by closing one eye. That is what differentiate between a functional convergent spasm with the organic. And if it is functional, you can disappear by asking the patient to close one eye, that will disappear.
Sir, here there was abduction, good abduction on the left side. So then how
Correct.
the convergence? Then how convergence spasm?
If you look at the abduction, see, convergent spasm is not all the time present. You don't all the time present. Moreover, if you look very carefully, you look at the eye movement. I'll show the first video. Okay? I'll show the first video once again. You see, the left eye does not go into abduction fully all the time, only occasionally. I'll come to that. Then you will understand that. Convergent spasm is not always uniformly present all the time. It may be present sometimes, it may not be present sometimes. Look at the eye movement now. The initial part I'll skip. No, this one. Okay. See, it's almost looking now. Abduction. There is restriction partly on the left side, totally on the right side. When you look to the left side again, you see the abduction may be incomplete. Up and down. Now look to the left side. See, the abduction is incomplete now. It's not fully coming now. And looking at the ocular cephalic also, you look at the abduction is not fully coming outside, according to the extent of normalcy. So that means it's episodically, you can make it abduct fully well, but sometimes probably the convergent spasm is occurring in between.
Could it be due to a latent squint on the left side?
Can be latent squint on the left side. That will be difficult. In the latent squint, you have to differentiate by doing this thing, adduction movement. I don't know the adduction movement here.
So on primary position, the left eye is adducted. It is because of the spasms.
Convergent spasms. Otherwise, you have to implicate a left lateral rectus weakness in this patient. But that is the point again, is that sometimes it goes into abduction fully. Sometimes it does not go into the full abduction. So that makes a lateral rectus weakness less likely in this patient.
Nice piece.
Okay, shall I go to the next case?
Yes, sir.
Okay. The story of a 60-year-old man. This is not a very problem case, straightforward case, but little odd presentation. History of dysarthria for the last 6 months. That is why it came to me. In fact, referred by this, I forgot to say this is a courtesy to Dr. Lovin, who has referred this case to me. There is no definite fluctuation. My difficulty in writing for the last 5 months. Tendency to deviate to the right while walking. That is the story. I'll tell you can hear the story. He is telling in Malayalam, but anyway, you can understand this.
പറയാൻ കുറച്ച്
Is it difficult speaking?
കയ്യെ പറ്റുന്നില്ല കുറച്ച്
Difficulty in writing?
വേദന വരുന്നു നടക്കുമ്പോൾ സൈഡിലേക്ക് പോകണം അപ്പോൾ ആൾക്കാർക്ക്
People are telling his
ഞാൻ പറഞ്ഞ പോലെ പറയാം. ഞാനിപ്പോൾ തിരുവനന്തപുരത്താണ് താമസിക്കുന്നത് എന്ന് ഉറക്കെ പറഞ്ഞു.
ഞാനിപ്പോൾ തിരുവനന്തപുരത്താണ് താമസിക്കുന്നത്.
ഓക്കെ, ഒന്നുകൂടെ പറഞ്ഞു.
ഞാനിപ്പോൾ തിരുവനന്തപുരത്താണ് താമസിക്കുന്നത്.
ഇനി ലാ 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 സ്പീഡ് ലാ 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 എന്ന് പറഞ്ഞു.
ലാ 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 ലാ
ഞാൻ പറഞ്ഞ പോലെ റിപ്പീറ്റ് ചെയ്യണം. പാ ക പാ ക അങ്ങനെ പറഞ്ഞു.
പാ ഡ ക പാ ഡ ക പാ
ട
ട
ക
ക
പാ ട ക
പാ ട ക പാ ട ക.
That's his speech. That is his handwriting. It has become clumsy. And his drawing a spiral also has become clumsy in the drawing a spiral. Then rest of the examination, eye movements normal. One is nystagmus. Other canine musculature is normal.
നീട്ടണ്ട. ആന്ന് പറഞ്ഞ് നാക്ക്
Back
നീട്ടിക്ക്.
movement normal.
വിട്ടോ.
I must say in a single tone.
ഒന്നുകൂടെ ഉറക്കെ ഒരേ സ്വത്തി പറഞ്ഞേ.
There is no spasmodic element dystonia. Spasmodic dystonia. Power of the lips normal.
മൂക്കിത്തുണ്ട് അങ്ങനെ ചെയ്ത്.
It's mild incoordination.
മറ്റൊക്കെ
Most normal. Mild incoordination is there. But he said his handwriting is defective. Motor system power of the normal. DTR all normal.
നേരെ
Sensations normal. Vibrations and joints normal. This is a way he walked. He said he was leaning to one side while walking, but on examination I couldn't find anything. Except a tandem walking was slightly defective. That is defective. He falls to a tendency to deviate to both sides. So speech, there could be some slurring dysarthria with stress on certain syllables, not a classical cerebellar speech. Kuri mild spasticity, I was not sure about it. And his difficulty in pronouncing certain syllables. Suppose Thiruvananthapuram, we will say Thiruvananthapuram, that part he becomes a difficulty in pronouncing that particular syllable in a particular word. Pataka, he said beautifully well, there is no apraxia. In say in a uniform tone, he was able to say there is no element of any spasmodic dystonia coming towards the end of the speech. Cranial is normal, motor system normal, DTR normal, sensory system normal, Romberg's negative, gait normal, tandem walking defective. So what is a likely localization and diagnosis? Possibility you can keep in mind.
It looks like dysarthria clumsy hand syndrome.
This is a duration is 3 months. Let me see 3 months, 3 or 4 months. It's called dysarthria is there. Gait also
Spastic
is.
type of spastic dysarthria there. It looks like
Yeah, yeah.
spastic dysarthria.
Yeah,
And there
I
is,
also thought some spastic element I also thought and some hesitancy in bringing out certain symptoms.
yeah. And also some clumsiness in the right hand.
Right, definitely. The bilateral it is there, or not say.
But duration is 3 months.
3 months, I think it's 3 months, 3 or 4 months.
So predominantly cerebral involvement with maybe some pyramidal involvement also.
Correct. But do you think speech is typically cerebellar or something else also? It could be cerebellar, but there is some interruption between coming.
Maybe
Anyway, it could be.
spasticity.
Maybe that's a possibility is there. Correct. But there is, in fact, unlike a spastic speech, you see uniformly there, it comes in between. That's the thing which is slightly odd for me. Like so spasticity, they speak like that. But here it is in between. That's the only odd point against spasticity. Otherwise, it could go with this mild. I also thought mild spasticity is there.
Maybe due
So
to
that may be because of the cerebral involvement, the intermittent.
Yeah, very well. That's a good part. That's a good thought. There's possibility. But otherwise, he's not showing intermittency. That's the problem.
Could it be due to dystonia, lingual dystonia?
Yeah, that's also can produce intermittent arrest of the speech. But I want to ask him to say that there's no spasmodic element is not coming there.
For the larynx, for the other parts,
Yeah.
like for
Yeah.
people or other, because
Correct. Yeah, as you said, correct. It may not be in the larynx. Maybe other things may be affected. Correct. That is coming only on task-specific speech. Sometimes it can produce like this. Agreed. So overall, what do you think?
Cerebellar plus pyramidal.
Cerebellar pyramidal. Likely possibility, 3 months.
Be a
Okay,
degenerative or paralytic.
Okay, so what investigation do you need here?
MRI.
MRI, okay.
brain.
So TFT was done. I came with TFT normal. Is not any particular drugs prior to this thing. And this is the MRI brought by the patient. This is the flare. Uppercut to the other cuts, and I'll come back to once again. I will show the MRI. What is the diagnosis?
It's
Any
nothing
thought?
much, no?
Pardon?
It's nothing much on the MRI, no? MRI looks.
I didn't get you, Joy.
MRI looks almost normal.
Okay, right. So what did you like to do? In fact, radiologist reported normal also.
brainstem is atrophy.
Pardon?
Brainstem atrophy is there, sir?
Let's see the brainstem atrophy. Okay. So I'll give some clue in the make the diagnosis. Okay. Then you go back to the MRI, you'll make, I'm sure that you will come get the diagnosis. Patient gave history of prominent RBD.
Brain.
Pardon? Now you go back to the MRI. Now you go back to the MRI and see he has got hyperdensity in the middle subulnar peduncle bilaterally. Did you see this one? And he has got a hot cross bun sign and atrophy of the pons. This is a middle subulnar peduncle atrophy, more on asymmetrically, more on one side. I'll come to the next film once again.
MSA.
This MSA, I'll come to that. Then look at the flare, you can make out the little suspicion of a hot cross bun sign. And definitely the cerebellum is atrophied. Sorry.
No, sir, folias are prominent.
See, this is cerebellar folia. This is quite prominent. Cerebellum is atrophied. It's a hot cross bun sign, and you can hyperdensity in the MCP. But the radiologist reported as normal. Now, I looked back only because I got the history of RBD in this patient. Then I thought it could go with that and see. So what other things will you like to do in this patient?
Iglon.
No, I know. I think it's typically his MSA only. So I asked the history of impotence. Wife has been telling he has been having this for the last 1 year. I checked his. That's possible, but it's only MSSC. He's got a cerebellar ataxia onset with this finding. It's MSSC only. He's got autonomic involvement.
Autonomic dysfunction.
Yeah, he has got a lying BP is 150/90, standing BP after 2 minutes is 120/80. So make it a point of when you see patients, immediately after getting up, you take the BP, it may not show some fall. It was only 130/90 immediately after 1 minute. After 2-3 minutes, it became much more low. So make it a point to check the BP or 2 minutes, 3 minutes, or even 5 minutes late. It's called prolonged postal hypertension. This patient had postal hypertension, even though he never complained of any postal giddiness. But examination, he had postal hypertension. And his prominent RBD was one of his complaints, which I did not say initially. Okay, is there a time for one more case or shall we stop?
More case, sir.
Okay.
One more case.
One more case even. Okay. This case is given to me by Dr. Gayatri. He has shown this case. This is the story of a 40-year-old diabetic old man, diabetic for about 25 years or so. His complaint started as clumsiness of the right hand for the last 3 months. He noticed generalized thinning on the right upper limb for many months. Exact duration he did not remember. Actually, he did not complain of thinning. When I examined, he found his right whole upper limb was thin. I asked him, when did he said it has been there a long time. He cannot say how long it has been there. No other complaint. His only complaint is clumsiness of the right hand. No paresthesia or complaints pertaining to the lower limb. This finding now. Canus normal, motor system deltoid, biceps normal. See, it's got a wasting on the introsea, more prominent, marked introsea wasting on the right side. On the right side. Finger extension is normal. Extensor pollicis is normal. Bilaterally. Longest previous normal. Extensor pollicis. Then long finger flexor is normal. Then the flexor pollicis brevis was normal on the left side. That is weak on the right side. Flexor pollicis brevis is weak. Abductor pollicis brevis is weak bilaterally on the left as well as on the right side. Opponent is also weak bilaterally, more severely on the right side. He could not oppose the thumb and the little finger on the left side. But it totally not possible on the right side. The introsea normal on the left side, weak on the right side. Roman sinus positive on the right side, normal on the left side. That is weak, palmar and weak on the right side. Left is almost normal. Maybe mild weakness of the fourth palmar introsea. There is no corner syndrome. Touch is telling decrease on the, touch is normal. Is counting correctly. When examine the pain, the telling decrease on the right finger. Is a decrease on the right middle part here. But taking the pin up is a normal. Is it same all throughout. Again, is telling decrease on the little finger. Decrease on the little finger. The dorsal aspect also. On the other hand, vibration is telling decrease on the thumb, normal on the little finger. The other way around. Is a decrease on the middle finger. Normal. Is a decreased. Normal. Is a decreased. However, joint senses normal in both upper. Is it correctly in the little finger? Is it vibration decrease on the index, but that by JPS is not? It's got some thinning on the whole of the right upper. The lower limb power was normal. When examined the reflexes, biceps supinator normally elicited. Triceps is wasted. See, triceps is absent. Moreover, it's wasted. That's how only when I understeam to check the reflex, I found the wasting. Wasting bilaterally is wasted, more on the right side. Finger flexion is absent. Abdominal is intact bilaterally. Knee jerk and ankle jerk diminished, almost absent. Ankle jerk also is decreased. I couldn't in fact elicit the ankle. He's a diabetic but long. And the plantar right was indefinite. Left is upgoing, or it is more like upgoing rather than withdrawal. That is not. The primary weakness is more on the right side, but right plantar.
Vibration
vibration decrease on the both. Joint presence is normal. Compulse is negative. Gait was normal. Taylor's no Horner syndrome. Motor generalized thinning of the whole of the right upper limb. Marked wasting of both triceps, thenar, hypothenar muscles, and introsea on the right side. Tone normal in both upper and lower limbs. Motor power, right upper limb, shoulder, elbow muscles normal. Wrist dorsiflexes, and palmar flexes, finger extensions, finger flexes are all normal. Weakness of all thenar, hypothenar muscles, introsion, adductor pollicis on the right side. Left upper limb, weakness of left abductor pollicis, brevis, and opponent's pollicis. Other muscles were not. Normal power of hypothenar, introsion, adductor pollicis on the left side. Lower limb, normal power. Detail upper limb, both biceps supinated normally ill-seated. Both triceps submental pressure absent. Lower limb, both knee and ankle jacks are absent. Abdomen refers normal. Plantar, right indefinite, left extensor. Cory withdrawal. More likely extend. Looks more like an extensor plantar. Sensation right upper limb. Pain decrease in the ventral and dorsal aspect of the right little finger and medial palm. On testing the pain sensation upward, taking the pin upward, he said normal all throughout. That was really confusing. Impaired vibration of the right thumb and middle finger, normal on the little finger. So I do not know how far to give significance for that. The joint presence is normal in all the fingers. Vibration decrease in the toes, otherwise lower limb normal. Left upper and lower limb, and all sensations normal except for the mild impairment of vibration on the both toes. Sorry, this is not left, both lower limb, not left upper limb. Rhombus negative, gait normal. So where is the localization?
The correlations, intrinsic correlation.
Intrinsic correlation?
Yeah, considering the wasting, the reflex loss, and the extensor plantar.
Okay.
Syringomyelia, something like that.
Syringomyelia. Okay. But this confined only to say C7, C8 segments if at all. And lower limb reflex are also absent. Abdominal reflex is intact. There is no spasticity in the lower limb. Power normal. The abdomen plantar is there, or is it a withdrawal? I do not know. I'm not very sure. So you mean to say syringomyelia extending all throughout the cord, or only confined to the cervical cord?
Only to the cervical cord. I mean, there's one possibility.
But there is no dissociative anesthesia per se.
Yes.
The curious thing is that he's a little confusing with the pain sensory loss. Pain is decreased on the ulnar distribution. Okay. But JPS is decreased telling is on the median distribution. Anyway, intramural lesion have one possibility of a strong leaky because of the brain plantar. That cannot ignore that. Okay, any other thoughts? It's little difficult now because he has been having thinning of the right upper limb for a long period of time. And now come with only complete confined with the upper limb. Is any other possibility? Can it be a mononeurous multiplex or something like a Hirayama which has been there for a long period of time?
But how to explain the sensory finding if it is something like Hirayama?
Sensory findings is not very convincing. That's why I said. If it is there, I would agree. It's not against, it is against Hirayama. And we have to keep all the possibilities. Sometimes patient may say the weak limb sensory loss and all. We do not consider. So the pain loss and the joint cells are not in the same distribution. That's the problem. Otherwise, we would have definitely believed him. Okay, so what are the possibilities you have to keep in mind? In fact, we don't know. We have to investigate. Pardon?
TAT1. Radiculopathy with compressive myelopathy.
Okay, radiculopathy, myelopathy. That's a good possibility. Okay, let us see the investigations now. These are the possibilities one you have to keep in mind. What investigation you need? NCS was done. This is NCS finding. Left peroneal, this velocity you ignore, that can go with the normal range, not abnormal. That amplitude is decreased in the left peroneal, right peroneal not obtained. But TA pickup is normal. Okay. Come to the upper limb. It's not obtained from the right median. Right ulnar is also grossly decreased amplitude, but velocity is normal. Left median amplitude is decreased. That goes with our clinical finding also. Because he has got weakness confined to the thenar muscle on the left side. On the right side, both thenar and hypothenar, both the thenar, hypothenar, and androsia are on the right side. And left ulnar was normal, 11. Now to the sensory is not obtained from the right median nerve. Right ulnar is all other things slightly normal. Mild decrease in the left ulnar and both ulnar. Otherwise normal. Now, lower limb, all senses, both supraperoneal and sural not obtained. FAV latency is not obtained from the right median and right ulnar and prolonged in the left median and not obtained on the right. That you ignore the right peroneal because amplitude was very low. So, what is the diagnosis after EDX? You want to see the EDX once again? This is the amplitude. Left peroneal amplitude is very low, right not obtained from the EDB. So we can't give importance for that FA on that side. Then upper limb that we are more interested in has got right median, right ulnar grossly affected, and left median is also affected. Distribution. Sensory, right median sensory loss. Right ulnar sensory is not affected much. Snap in the lower limbs are absent. FA, right median and right ulnar not obtained. Left median prolonged. Any thoughts?
Polyneuritis multiplex going on to polyneuropathy.
Yeah. Yeah, that's the thing we have to start consider putting up the NR finding. Okay. So because he's got a sensory loss also is there, we have to consider lesions with the periphery. But median of sensory, again, this is the problem in neurology. There may be comorbidities. He's got a chronic diabetic for 25 years. He can very well have associated carpal tunnel syndrome. That can result in loss of sensory loss. That's how again you have to keep in mind. Okay. Am I audible to you?
Yeah.
Yes, sir.
Yes, sir.
Okay. The current suddenly went up. There is a doubt. Okay. Right. So let us see. What do you think about after NCS? What do you think about the site of lesion?
Could it be mononeuritis multiplex?
Yeah, it could be. It could be. Right. Let us see. So Mercury mononeuritis multiplex. What is odd again is the mononeuritis multiplex.
But in the left median, the prolongation of the F wave.
Yes, point number 1. Very good. The other point is let's see the maximally affected muscles on that. Which is the maximally affected muscle on the right hand, small muscles, right? Interossei and this thing. And look at the CMAP for the median ulnar on the right side. See, this is the median CMAP, not elicited. Right ulnar, again, almost absent. Okay. Now, the sensory loss is there only in the right median and not in the ulnar. Ulnar is a maximally affected muscle, hand and the nerve on the right side. Look at the snap here. Right median is lost, ulnar is not lost. So what does it tell you? Does it go with your mononeuritis? You
No,
can
it
say,
will.
yeah, that's slightly odd. No, that means you have to think of lesion proximal to the ganglion. So lesion causing interossei hypothalamus is not due to the peripheral nerve lesion. Because if it is median nerve is producing sensory loss, why not ulnar producing lesion that way? Okay. Moreover, he complains of numbness in the ulnar distribution. Touch sensitive pain was decreased on that side. If you take it that value into consideration, again, that makes it little odd. So This is the MRI of the patient. What do you see in the MRI? This axial cut. It's got a dorsolateral disc protrusion compressing the cord on the right side. But still there is a serious space in between. That's a dorsal. I'll go back to the once again, the MRI finding. This is the MRI dorsal spine, cervical spine. Upper cut, C2, C2, C3. That comes C3, C4, C4, C5, C5, C6, C5, C6, C6, C7. So what is your diagnosis now?
C5, C6 was producing.
Okay. So what is your final diagnosis? You find something there, but how do you explain it, correlate everything together? What advice will you give the patient?
Surgical.
Surgery. Pardon?
Surgical.
Surgery. Okay. Surgery,
Because
he has no problem in walking. He has come with no problem in difficulties, only come with wasting and weakness of the right hand. So it's a surgery, you do the surgery and your hand will improve.
this hand intrinsic muscle is due to the ischemic myelopathy, sir.
Very good. That's the point. See, he has got a compression is the ultimate, the culprit is a compression, but the damage to the cord is not due to the compression. That's the point you have to very clearly make it out here. The cord compression is very minimal if at all, because the only pyramidal sign he has was only upward plantar on the left side, that on the left side, not on the right side. Okay, and no spasticity in the lower limb, no weakness in the lower limb, no sensory loss in the lower limb. So the main thing which has caused him is that there is anterior loss, something like a kirayama, but due to ischemia to the cord. So you have to advise surgery, but make the point very clear to him that this surgery is only to prevent a further progression. You cannot escape from the wasting will not go into improve. Okay, that's the story of the case. See, initially it's not that easy, simple to make it easy to make a diagnosis of cerebral spontaneous myelopathy here. Because anticonstant is the one which is dominantly there in this patient. Mimicking Hirayam, something like Hirayam.
Thank you, sir.
Okay. Yeah. Any questions?
So can we call it as a myelopathic hand like the other? Is it some?
No, this is not a myelopathic hand. Myelopathic hand is classically the affected the medial part. That finger will go into little finger will go in the abducted position, and the medial two fingers will drop down. Okay, so the lateral three fingers will be normal. It will be like this. That is a myelopathic hand. The first thing is that abduction sign of the little finger. Then the other finger, the ring finger will get affected. Then both the ring and little finger will droop down. That is myelopathic hand. And that will not be confining to a dermatomal or myotomal pattern. Sorry, dermatomal and myotomal pattern. Yes, Bindu?
Yes, here, as you said, the right little finger joint position sense is affected.
Not affected. No, it's not affected.
It is not affected.
That's the whole thing. No? If we had affected, it would have been straight away made us a cervical myelopathy. He said it decreased pain, but joint pressure is normal in the little finger, but it says the vibration. Joint pressure is normal throughout. He said vibration is decreased on the thumb and the index finger. That is the whole confusion came.
Okay, sir.
Okay. Any questions before I close? Okay, then. So good night. See you next week.
Thank you, sir.
Good night,
Thank you, sir.
Good night.
Thank you.
Good night.
Thank you, sir. Good night.
Good night, sir.
Good night. Good night.
Night,
Good night.
sir.
Thank you. Thank you.